Welcome to the Radonc Smart Review GU Cancer series. This is episode 19, Testicular Cancer, Workup, Markers, Staging, and Stage I Seminoma.
It's funny, if we rewind the clock to like the early 1970s, a diagnosis of metastatic testicular cancer was essentially a death sentence.
Wow, really?
Yeah, I mean, the survival rate was hovering somewhere around like 5%. It was just a bleak, devastating conversation to have with a young man.
That is just incredibly grim.
It was. But fast forward to today, and we are looking at a cure rate that exceeds 95% across the board.
That's amazing.
Right. The introduction of cisplatin-based chemotherapy, plus, the refinement of surgical and radiotherapeutic techniques, it completely revolutionized the landscape.
And that staggering historical contrast, well, it fundamentally changes the modern clinical mindset.
Oh, absolutely it does.
When a man in his 20s or 30s sits in the consult room today, the dominant question is no longer whether we can cure the disease, right? We have an incredibly high degree of certainty that we will.
Exactly. The modern clinical challenge is figuring out how to secure that cure while, minimizing the long-term, potentially devastating toxicities.
Because we're talking about someone who is going to live for another 40, 50, or even 60 years.
Precisely. We have to view every single intervention through a survivorship lens from the very first encounter.
Yep.
It dictates everything from the initial diagnostic steps to the follow-up imaging 15 years down the line.
So to really wrap our heads around the sheer number of decision points involved, let's trace a single patient's journey. Let's use an anchor case for this.
That sounds like a great plan.
Okay, consider a 32-year-old man presenting to the clinic with a painless left testicular enlargement. He noticed a change in firmness and size a few weeks ago, but just ignored it.
Which is such a common narrative, honestly. Guys just assume it's a minor injury or a strain.
Right, exactly. So he finally comes in, undergoes a scrotal ultrasound with Doppler, and it reveals a solid intratesticular mass.
Okay, classic presentation.
Yeah. Blood is drawn for pre-orchiectomy serum tumor markers, and the results show a normal alpha-fetoprotein, a modestly elevated human chorionic gonadotropin, and a mildly elevated lactate dehydrogenase.
Got it.
And before any surgery happens, he completes fertility counseling and sperm banking.
Essential step right there.
Truly. Then he proceeds to a radical inguinal orchiectomy. The final pathology report confirms pure seminoma confined entirely to the testes.
And how did his markers look after the surgery?
Post-orchiectomy, his tumor markers normalize completely, and his subsequent staging with a cross-sectional computed tomography, or CT, of the abdomen and pelvis shows no retroperitoneal lymphadenopathy. Plus, his chest imaging is perfectly clear.
Well, there it is. This is the quintessential presentation of clinical stage I seminoma.
A solid mass, surgically removed, pathology confirming pure seminoma, normalized markers, and negative imaging.
Yep. And the ultimate consult question that arises for you in this scenario is determining the best post-orchiectomy management strategy.
Right. But before we rush into that final decision, we really need to scrutinize the foundational rules of the initial workup.
We do, starting with the very first imaging modality.
Exactly. When our 32-year-old felt a painless mass, the immediate diagnostic tool was the scrotal ultrasound with Doppler.
And we rely on Doppler because it evaluates blood flow.
Yeah, if it's just a simple anechoic fluid-filled cyst, it will show posterior acoustic enhancement and, crucially, no internal vascularity.
Right, which points to a benign process.
But a solid mass with internal blood flow, that flags a lesion as highly suspicious.
Honestly, a solid intratesticular mass with internal vascularity on ultrasound is basically guilty until proven otherwise.
Guilty until proven otherwise.
Right.
I like that.
It is a malignancy until a pathologist definitively proves it isn't. And because of this high index of suspicion, the sequence of the next steps is completely rigid.
Meaning the tumor markers.
Right, exactly. Serum tumor markers, specifically alpha-fetoprotein, human chorionic gonadotropin, and lactate dehydrogenase, must be drawn prior to any intervention.
Because we need a baseline to understand the tumor's biological activity.
Yeah, and to track its clearance later. If you don't get them before surgery, you lose a massive piece of the diagnostic puzzle.
And wedged right between that ultrasound and the operating room is a conversation that just cannot be skipped, which is fertility counseling.
It's so critical. The psychological shock of a cancer diagnosis often overrides a patient's long-term priorities in that exact moment.
Their instinct is just, get the cancer out of me right now.
Exactly. However, the orchiectomy itself, combined with the stress of the diagnosis, can cause a temporary or permanent decline in spermatogenesis.
So we have to hit the pause button on the cancer treatment, just long enough to ensure sperm banking is offered and completed.
Right. Having that conversation post-surgery, when physiological changes have already occurred, is basically a failure in the standard of care.
Protecting the patient's future family planning options is really the first application of that survivorship lens we talked about.
It is. And once sperm banking is secured, the definitive surgical management is a radical inguinal orchiectomy.
And the surgical approach here is paramount. Violating a very specific anatomical boundary carries catastrophic consequences for the prognosis.
It really does. So the absolute contraindication, like the major never do this rule, is attempting a transscrotal biopsy or a transscrotal approach to the testicle.
I always think of a localized cancer, like a house fire that's currently contained inside a single thick-walled room with the door shut.
That's a great analogy.
Right. If you walk up to the outside of the house and smash a window to look inside, the sudden change in draft and pressure pulls the fire directly toward the opening.
You give the fire a brand new avenue of escape.
Exactly. A transscrotal biopsy does exactly that. By cutting through the scrotal skin and breaching the tunica albuginea, the tough fibrous layer containing the testicle, you disrupt the natural tissue planes.
And you risk seeding cancer cells right into the scrotal sac.
Yeah, and rerouting the lymphatic spread toward the superficial and deep inguinal lymph nodes.
Which is an area where testicular cancer does not naturally spread early in its disease course.
So what's the alternative? How does the surgeon avoid that?
By going through the inguinal canal, making the incision higher up in the groin. This way, the surgeon can ligate the blood supply early and pull the entire testicle, the epididymis, and the spermatic cord up and out as a single undisturbed unit.
The tunica albuginea remains intact. The fire stays trapped in the room.
Exactly. This preserves the natural, predictable lymphatic pathways. And that becomes critical if the patient ever experiences a relapse and needs localized therapy.
You know, some might wonder if an MRI is necessary before taking the dramatic step of removing the entire testicle.
I get that question a lot, especially since in prostate cancer, a multiparametric magnetic resonance imaging, or MRI, is standard before a biopsy.
Right, but an MRI of the scrotum is not part of the standard initial workup here.
No, it's not. The ultrasound with Doppler is incredibly sensitive and specific for differentiating cystic from solid masses.
And given our golden rule that a solid mass is guilty until proven otherwise, confirming a vascularized solid mass on ultrasound is all the imaging evidence you need to proceed straight to the inguinal orchiectomy.
Adding an MRI just introduces unnecessary cost, delays definitive diagnosis, and honestly provides no additional actionable data.
It doesn't change the immediate surgical plan at all.
Not one bit. And the physical removal of that intact unit via the inguinal canal prevents the artificial rerouting of microscopic disease.
Which forces us to look closely at where those microscopic cells actually travel when left to their natural biological devices.
Yes. Understanding the natural lymphatic drainage of the testicles is literally a cornerstone of genitourinary oncology.
Because unlike most pelvic organs, which drain into the nearby obturator or internal iliac lymph nodes, the testicles drain straight to the retroperitoneum.
Which is so peculiar, but it's entirely due to embryology.
Right. During fetal development, the testicles originate way high up in the abdominal cavity near the developing kidneys.
And as the fetus matures, they descend through the abdomen, navigate the inguinal canal, and settle into the scrotum.
And as they make this long descent, they drag their blood supply, their nerves, and their lymphatic vessels down with them. The plumbing basically remains connected to their embryological origin.
The simplest way to remember this anatomy for the boards, and just for life, is the phrase, the testes drains up, not down.
The testes drains up, not down. I love that.
And the destination of that upward drainage is highly predictable. Left-sided primary tumors typically drain first toward the para-aortic lymph nodes, settling in areas just inferior to the left renal vein.
And the right-sided ones?
Right-sided primary tumors drain toward the paracaval and interorcaval lymph nodes, situated between the aorta and the inferior vena cava.
This predictability is the foundation of how we stage the disease and, historically, how we designed our radiation fields.
Yeah, and it's exactly why the patient's surgical history is such a critical component of your initial physical exam.
Oh, because of prior surgeries altering the pathways.
Exactly. If our 32-year-old had an inguinal hernia repair with mesh as a child, or surgery for an undescended testicle, like an orchiopexy, that creates scar tissue.
And scar tissue alters the normal lymphatic channels, forcing the lymph fluid to find new collateral routes.
Right. A previous violation of the groin or scrotum means the cancer might abandon the classic retroperitoneal highway and instead metastasize to the pelvic or inguinal lymph nodes.
The natural barriers have been compromised, so the expected relapse pattern becomes much wider.
Exactly. And recognizing those anatomical pathways really informs the subsequent staging.
So following the orchiectomy, the pathology report is the definitive turning point in the management algorithm.
It is. Testicular germ cell tumors are broadly divided into two major histological categories: seminomas and non-seminomatous germ cell tumors.
Seminomas tend to present slightly later in life, right? Often in the 30s and 40s.
Yes, they grow somewhat more slowly,
Yeah.
and they're exquisitely sensitive to both radiation and chemotherapy.
Whereas non-seminomas, which encompass things like embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma, they are generally more aggressive and present in younger men, often in their 20s.
Right.
But wait, I am looking back at the initial lab values for our 32-year-old anchor case. His pre-orchiectomy markers showed a modestly elevated human chorionic gonadotropin, or beta-HCG.
I see where you're going with this.
If his beta-HCG is up, doesn't that inherently mean we are dealing with a mixed tumor containing non-seminomatous elements? I thought pure seminoma shouldn't produce elevated tumor markers.
That is a very common misconception and a classic board trap. Pure seminomas can, in fact, produce beta-HCG.
Wait, really?
Yeah, roughly 10 to 20% of pure seminomas will have an elevated beta-HCG at presentation.
How does that happen?
It occurs because the tumor can contain syncytial trophoblastic giant cells, and those secrete the hormone. So a modestly elevated beta-HCG in a patient whose pathology shows pure seminoma is biologically consistent. It does not alter the diagnosis.
Ah, okay. But the rule completely changes when we look at the other major marker, alpha-fetoprotein.
Completely changes. Pure seminoma does not produce alpha-fetoprotein, period.
Because AFP production is driven by yolk sac elements, which are definitively non-seminomatous.
Exactly. So if a pathology report declares a tumor to be pure seminoma, but the patient's serum AFP is clearly reliably elevated, there's a fundamental contradiction.
So what do you do in that scenario?
The serum marker overrides the slide. You assume the pathologist simply missed a microscopic focus of yolk sac tumor in the gross specimen, and you must manage the patient entirely according to the non-seminoma algorithms.
The serum marker overrides the slide. That is a massive pearl. But you use the phrase reliably elevated.
Yes, that caveat is important. Alpha-fetoprotein is synthesized by the liver, so various non-malignant hepatic conditions like hepatitis, cirrhosis, or even mild liver dysfunction can cause slight stable elevations in AFP.
So borderline elevation requires careful interpretation of the clinical context.
Right. We rely on the kinetic decay of these markers to provide clarity.
Kinetic decay, which is essentially tracking the half-life of the marker in the bloodstream after the tumor has been removed.
Exactly. If the source of the protein is gone, the protein levels should drop at a mathematically predictable rate.
So what are the expected half-lives?
For alpha-fetoprotein, it's roughly 5 to 7 days. For beta-HCG, it's much faster, typically 24 to 36 hours, but generally taught as 1 to 3 days.
So if an AFP was elevated at 100 before surgery, a week later it should drop to 50, and a week after that down to 25, steadily trending toward normal.
Exactly. And if the markers fail to decline according to their half-lives, they plateau, or if they begin to rise post-orchiectomy,
Then what?
it is absolute biological proof that viable tumor cells remain somewhere in the body. It indicates persistent or metastatic disease, regardless of what the imaging scans show.
Because the markers often detect microscopic disease burdens far below the resolution limit of a CT scan. Speaking of imaging, once the local disease is removed and the markers are trending appropriately, we evaluate the rest of the body to determine the anatomical stage.
And standard cross-sectional imaging includes a CT of the abdomen and pelvis to assess those retroperitoneal and pelvic lymph nodes.
Plus, chest imaging is required to rule out pulmonary metastases.
Right. But the choice of chest imaging for a patient with an otherwise clean abdomen and pelvis who is suspected to have Stage I Seminoma leans toward a simple chest X-ray rather than a full CT of the chest.
Really? A standard X-ray is enough?
Yes, because the probability of isolated lung metastases in pure seminoma without concurrent retroperitoneal disease is exceptionally low.
That makes sense. And a chest CT delivers a non-trivial dose of ionizing radiation to the breast tissue, lungs, and thyroid of a young man.
Exactly. Not to mention, it frequently identifies tiny, indeterminate pulmonary nodules, like benign granulomas or kinase scars, that provoke immense anxiety and trigger a cascade of unnecessary follow-up scans.
So a chest X-ray provides sufficient staging information while adhering to the survivorship principle of minimizing iatrogenic harm.
Spot on. Additionally, functional imaging, like a positron emission tomography, or PET scan, has absolutely no established role in the routine initial staging of testicular cancer.
Right, because it yields a high rate of false positives from baseline inflammation and doesn't improve the accuracy of standard CT scans in this setting.
Exactly.
So synthesizing the pathology, the markers, and the imaging brings us to the formal staging.
Right. Stage I indicates disease confined entirely to the testicle. Stage II implies spread to the regional retroperitoneal lymph nodes.
And stage 3 indicates distant metastases beyond the retroperitoneum, like the lungs, liver, or bone, or is defined by persistently elevated tumor markers after surgery.
For clinical stage I, there is a specific subclassification in the AJCC 8th edition staging manual that's worth noting.
Oh, the size cutoff.
Yeah, pure seminomas confined to the testes are subdivided into PT1A and PT1B based on a size cutoff of 3 centimeters. A tumor of 3 centimeters or smaller is PT1A, while anything larger is PT1B.
Okay, but this distinction just helps stratify the statistical risk of occult microscopic disease, right? It remains a T subclassification.
Exactly. The overall stage is still stage I, and crucially, falling into the PT1B category does not automatically trigger a mandate for adjuvant therapy.
Okay, so returning to our anchor case, our 32-year-old patient has a clean CT of the abdomen and pelvis, a clear chest X-ray, and fully normalized Merkel's following his orchiectomy.
Yep, he is definitively categorized as having clinical stage I pure seminoma.
Which brings us finally to the central consult question. What is the preferred post-orchiectomy management strategy?
The preferred standard of care strategy for stage I pure seminoma is active surveillance.
Assuming he can stick to the follow-ups.
Very much so. It is heavily contingent on the patient's willingness and ability to adhere to a rigorous follow-up schedule.
Proposing surveillance to a young man who just had a cancerous organ removed often requires a very delicate explanation. Their instinct is usually to demand chemotherapy or radiation to, quote, make sure it's all gone.
Yeah, we really have to break down the underlying logic for them. Surveillance is not a default choice because adjuvant therapies are ineffective.
Right. Adjuvant radiation and adjuvant single-agent chemotherapy are profoundly effective at preventing a relapse.
The issue is the denominator. The orchiectomy alone cures over 80 and sometimes up to 85% of patients with stage I seminoma.
So if we universally applied adjuvant therapy to 100 men with stage I seminoma, we would be administering cytotoxic chemotherapy or ionizing radiation to roughly 85 men who were already completely cured by their surgery.
Exactly. We would subject them to the acute toxicities and the long-term delayed risks of those treatments for zero added oncologic benefit.
That's a huge overtreatment problem.
It is. By employing surveillance, we withhold immediate treatment, knowing that if the remaining 15% do experience a retroperitoneal relapse, we catch it early with routine imaging.
And at the time of relapse, the disease is still highly curable.
Extremely curable. With either radiation or chemotherapy, salvage rates approach 100%.
The ultimate cause-specific survival for stage I seminoma is nearly 99%, whether you use adjuvant therapy upfront or salvage therapy at the time of relapse.
So surveillance simply spares the vast majority from unnecessary treatment.
But we should be clear, surveillance is an active, demanding process. It is a major commitment to a heavily structured schedule.
Oh, absolutely. The National Comprehensive Cancer Network guidelines outline a regimen that primarily relies on cross-sectional imaging to monitor the retroperitoneum.
What does that schedule look like for the patient?
A patient can expect to undergo a CT scan of the abdomen, with or without the pelvis, every 6 months for the first 2 years. Then from years 3 through 5, the frequency decreases to every 6 to 12 months.
And chest X-rays and serum tumor markers are incorporated based on clinical suspicion. But that abdominal CT is really the workhorse of the protocol.
It is. And the psychological weight of this protocol cannot be overstated. Patients undergo a phenomenon widely recognized as scanxiety.
Scanxiety. Yeah, I hear about that a lot.
Every 6 months, their lives basically grind to a halt as they wait for the radiologist's report. Knowing a recurrence means initiating the heavy treatments they initially avoided.
So, for a patient whose job requires constant international travel, or someone who lacks reliable health insurance, or a patient whose generalized anxiety severely degrades their quality of life between scans.
Surveillance becomes inappropriate. We have to assess the psychosocial stability and logistical reliability of the patient just as carefully as we assess their pathology report.
Historically, we relied on specific pathological features in the primary tumor to predict who belonged in that 15% relapse group, right?
We did. Features like a primary tumor size greater than 4 centimeters and the presence of retet testis invasion.
Right, where the cancer cells infiltrate the network of tubules at the hilum of the testicle. Those were viewed as massive red flags.
They were.
So, do these traditional risk factors force our hand today? Like, if our 32-year-old had a 5-centimeter tumor with retate testes invasion, are we ethically obligated to abandon surveillance and recommend adjuvant therapy?
No, we aren't. While those features mathematically correlate with a higher risk of occult retroperitoneal disease shifting, the relapse probability closer to 30% modern consensus strongly emphasizes that they do not absolutely mandate adjuvant therapy.
So, they're more like data points for shared decision making.
Exactly. You sit with a patient, explain that their specific pathology carries a slightly higher risk of the cancer returning, and you weigh that against their tolerance for anxiety and their fear of chemotherapy or radiation.
And even with high-risk features, surveillance remains a completely valid and frequently preferred option because the majority of those patients will still never need additional treatment.
Right. But when a patient is entirely averse to surveillance, maybe the anxiety is paralyzing or they are deploying overseas and cannot access a CT scanner, we pivot to adjuvant therapy.
And the dominant evidence-based alternative to surveillance is chemotherapy, specifically a single cycle of the drug carboplatin.
Yes. Carboplatin acts by creating cross-links in the DNA of the cancer cells, interfering with cell division and triggering apoptosis.
And unlike cisplatin, its heavier and highly nephrotoxic relative used in advanced disease, carboplatin is primarily cleared by the kidneys and is dosed entirely differently.
Right, we use a single cycle of carboplatin dosed at an area under the curve, or AUC, of 7.
The mechanics of AUC dosing require a brief explanation because it differs fundamentally from how we calculate most chemotherapy.
Yeah, typically drugs are dosed based on body surface area milligrams per square meter.
But carboplatin dosing relies on the Calvert formula, which targets a specific concentration of the drug over a specific period of time in the bloodstream.
And because the drug is cleared by the kidneys, the formula incorporates the patient's glomerular filtration rate, or GFR.
So an AUC of 7 ensures the patient receives a highly predictable, standardized exposure to the active drug, minimizing the risk of underdosing a young man with robust kidney function or dangerously overdosing someone with mild renal impairment.
Exactly. The clinical evidence supporting this specific regimen stems primarily from a massive medical research council trial that compared a single cycle of carboplatin at AUC 7 directly against adjuvant radiation therapy.
And the trial demonstrated that a single dose of carboplatin was non-inferior to radiation in preventing retroperitoneal relapses, right?
Yes, and it came with a different, often more favorable acute toxicity profile.
A single cycle of carboplatin is generally well tolerated. Patients usually experience manageable fatigue and mild nausea, largely controlled with modern antiemetics.
The primary acute toxicity is myelosuppression, specifically thrombocytopenia, which is a temporary drop in platelet counts occurring a few weeks after infusion.
While it sounds vastly preferable to the long-term risks of radiation, it is critical not to frame this as a trivial intervention. It is systemic cytotoxic chemotherapy.
Right. Rare but severe reactions can occur, and there is still ongoing research monitoring these cohorts for subtle, delayed cardiovascular or metabolic effects decades later.
The comparison to radiation brings us to the historical heart of Stage I Seminoma management. For decades, the undisputed gold standard was adjuvant radiotherapy.
Seminoma cells are incredibly sensitive to ionizing radiation. A relatively low dose can eradicate microscopic retroperitoneal disease with a local control rate nearing 100%.
However, radiotherapy has largely fallen out of favor as a routine upfront option.
Precisely because we started looking at the 50-year horizon instead of the 5-year horizon.
The long-term survivorship data for young men treated with abdominal radiation in the 1970s and 80s revealed deeply concerning trends.
The primary issue was the induction of secondary solid malignancies. Delivering ionizing radiation to the abdomen involves irradiating normal, healthy tissues. The stomach, the pancreas, the bowel, the kidneys, and the bladder.
And 15, 20, or 30 years after being cured of their testicular cancer, these men were developing radiation-induced stomach or pancreatic cancers, which are vastly more lethal than the seminoma they originally faced.
Yeah, there was also a notable increase in premature cardiovascular disease and metabolic syndrome due to the radiation exposure to the major abdominal vessels.
So to mitigate these toxicities, the field went through a rigorous process of de-escalation, trying to find the absolute minimum amount of radiation necessary.
And understanding how we deliver radiation today requires knowing the history of two landmark trials from the Medical Research Council.
Let's get into those. The first major shift involved reducing the volume of tissue we irradiated.
Right. Historically, the standard target was a dogleg field.
This massive field covered the para-aortic lymph nodes in the upper abdomen and extended down along the ipsilateral external iliac lymph nodes in the pelvis, literally shaped like a dog's hind leg.
The logic at the time was prophylactic. Since the testicle originates in the abdomen but passes through the pelvis, clinicians wanted to cover every conceivable pathway of microscopic spread.
However, the MRC-TE10 trial challenged this by randomly assigning patients to receive either the massive dogleg field or a smaller field isolated only to the para-aortic region.
And the trial proved that eliminating the pelvic portion of the field dramatically reduced acute gastrointestinal toxicity and long-term complications.
There was a statistically insignificant, tiny increase in isolated pelvic relapses, but those few relapses were incredibly easy to salvage and cure with subsequent therapy.
Exactly. So the para-aortic-only field became the new standard target volume.
Okay, so that's the field size. The second phase of de-escalation focused on the radiation dose itself.
Yes. The MRC-TE18 trial took the established para-aortic field and randomized patients to receive either the historical standard dose of 30 gray or a reduced dose of 20 gray, delivered in 10 daily fractions of 2 grays each.
And the lower dose of 20 gray was proven to be entirely non-inferior in preventing relapses, while causing significantly less acute lethargy, nausea, and long-term damage.
Right. So in contemporary practice, adjuvant radiotherapy for Stage I Seminoma is rarely utilized, reserved for highly selected cases where surveillance is impossible and carboplatin is contraindicated.
But if you are forced into that rare scenario, the technical execution of the treatment must prioritize the physics of tissue sparing.
The standard approach is a dose of 20 gray in 10 fractions to the periaortic lymph nodes.
But the delivery method is fascinating because it contradicts modern trends in radiation oncology.
It really does. For almost every other solid tumor, we rely on intensity-modulated radiation therapy, or IMRT.
Utilizing computer algorithms to shape the radiation dose tightly around complex targets.
Yet, for a Stage I Seminoma, utilizing IMRT is strongly discouraged.
And the avoidance of IMRT is rooted in the physics of how that tight dose sculpting is achieved.
IMRT uses multiple radiation beams entering the body from numerous angles, or a continuous arc of radiation rotating around the patient.
While this creates a highly conformal high-dose region, the physical trade-off is that a much larger volume of normal, healthy tissue receives a very low dose of scatter radiation.
This phenomenon is known as the low-dose bath.
Now, in a 75-year-old patient with localized prostate cancer, the low-dose bath is a perfectly acceptable trade-off to protect the rectum and bladder from high doses.
Because the latency period for secondary cancer to develop is often longer than the patient's remaining life expectancy.
But bathing the abdominal organs of a 32-year-old in low-dose radiation maximizes the volume of tissue at risk for a secondary malignancy that might emerge when he's 60.
Exactly. The risk of secondary cancers is heavily dependent on the total volume of normal tissue irradiated, even at low doses.
Therefore, we revert to a simpler, older technique. 3D conformal planning using parallel opposed fields.
We use one beam entering directly from the front, the anteroposterior, or AP field, and one beam entering directly from the back, the posterior-anterior, or PA field.
And this simple AP-PA arrangement effectively covers the para-aortic nodes while dramatically limiting the low-dose scatter to the surrounding abdominal cavity.
It minimizes the integral dose to the patient's entire body.
And alongside managing the low-dose bath, protecting the patient's remaining testicle is critical for preserving his natural testosterone production and any remaining fertility.
Right. The remaining testicle is subjected to radiation from two sources. Internal scatter occurring inside the body as the beams pass through the abdomen, and external leakage penetrating through the head of the linear accelerator machine.
We mitigate this by employing a physical testicular shield.
A lead clamshell shield is physically placed over the scrotum during daily treatments,
While the shield cannot block the internal scatter traveling down through the patient's tissues, it is highly effective at blocking the external transmission dose from the machine.
which significantly reduces the cumulative radiation dose to the remaining functional testicular tissue.
All right, let's distill these intricate protocols into high-yield, rapid-fire clinical scenarios for our board blitz. I will present the clinical trap, and you provide the definitive navigation.
Let's do it.
Trap number 1. You are evaluating a post-orchiectomy pathology report that explicitly diagnoses pure seminoma. However, the patient's preoperative alpha-fetoprotein was 150, and it remains elevated at 80 a week after surgery, with perfectly normal liver function tests. How do you categorize and manage this disease?
The disease must be categorized and managed as a non-seminomatous germ cell tumor. Pure seminoma biology completely lacks the capacity to synthesize alpha-fetoprotein. An unexplained, reliably elevated, and kinetically consistent alpha-fetoprotein dictates that occult yolk sac elements are present, superseding the histological findings on the slide.
Perfect. Trap number 2. A young man presents with a painless, rock-hard swelling in his right scrotum. Ultrasound confirms a solid mass with internal vascularity. What is the immediate next step, and what is the absolute surgical error to avoid?
Following mandatory serum tumor markers and fertility preservation counseling, the immediate next step is a radical inguinal orchiectomy. The absolute surgical error is performing a transscrotal biopsy or orchiectomy, which breaches the tunica albuginea, violates the natural tissue planes, and opens the door for atypical lymphatic spread to the inguinal nodes and local scrotal recurrence.
Excellent. Trap number 3. A patient is successfully diagnosed with clinical stage I pure seminoma. What is the default standard of care recommendation for management going forward?
Active surveillance is the default recommendation, provided the patient is psychologically capable of managing the anxiety and logistically capable of adhering to a rigid schedule of cross-sectional abdominal imaging for up to 5 years.
Right. And finally, trap number 4. In a highly unusual scenario where a patient with stage I pure seminoma absolutely refuses surveillance and has an absolute contraindication to carboplatin chemotherapy, you are consulted for adjuvant radiotherapy. What specific dose, target volume, and technique are required?
The standard is a dose of 20 gray delivered in 10 fractions. The target volume is strictly limited to the periaortic lymph nodes, and the technique must utilize simple AP-PA3D conformal planning to minimize the low-dose bath, explicitly avoiding IMRT and incorporating testicular shielding to protect remaining endocrine function.
Spot on. So the complexity of managing stage I disease lies entirely in the restraint required to avoid overtreatment.
However, the paradigm shifts aggressively when the disease progresses. In our next analysis, we will explore the management of Stage II seminoma, where the cancer has visibly established itself in the retroperitoneal lymph nodes.
And in that setting, the luxury of surveillance vanishes, and a highly nuanced debate between the efficacy of radiotherapy versus multi-agent systemic chemotherapy takes center stage.
Yes, the transition from active observation to deploying aggressive, localized, or systemic therapy requires an entirely different clinical calculus.
And as we close out the management of early-stage disease, consider a provocative frontier in the surveillance protocol.
Oh, this is fascinating.
Currently, we rely on the crude anatomical changes seen on CT scans, subjecting patients to massive anxiety and cumulative radiation exposure just to look for enlarged lymph nodes. But what if we could bypass the imaging entirely?
Emerging research is heavily focused on microRNA targets, specifically miR-371, a biomarker found in the blood that appears highly specific to active germ cell tumors.
If a simple blood draw could detect microscopic relapse months before a lymph node physically enlarges on a scan, we could completely eliminate the reliance on CT imaging, eradicate anxiety, and revolutionize the entire survivorship experience. Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.